Well, anyways, let's look at this patient. So she's a nursing student. She's a very good patient, anxious. She's engaged to the military guy who is always away, and she has a little bit of TMJ problem. That's her smile. So let's look at her face. So she has she's blonde hair. Her forehead is fine. She has eyebrows that are okay. Eyes, nice, beautiful eyes. But what distracts from those eyes is her bulbous nose and shallow smile, and kind of that protrusive face a little bit. So let's look at her profile. Again, forehead is nice ears. Her eye is in front of the cheek. Nasal hum, very distinctive nasal length here, and very poor dental support for her lips. Her face is, so to speak, squashed, and you can see that all this profile is just not supported by the skeleton at all. She has a little double chin. She's not overweight or anything like that, but that's her problem. So I think her main problem is nasal base, nasal projection. That's a good term. And then if you look at the angle, you can't even define it because it's just the nasal projection is so large. You want it to be smaller to have that lip definition better. But let's see what we did. She has very minimal dental deformity. Dr. Nolly, what do you think? That could be treated with therapy probably. But she's referred for the orthognathic surgery because she wants one-stage procedure. So all those patients, we have to talk about their profiles, and we plan it in 2D first and show them how they may look like. This is not bad occlusion. She only has crossbite on one side. She probably could get one piece, two-piece or three-piece lip fork and lip for mandible alone. She would be fine, or even get SARPI, or even get a palatal expander of some sort, just minimal surgery. So her SAF is here, and this is her after surgery. So I'm showing you a picture right after so we can discuss it. So look at her pupil now and look at her cheek. Look at her nasal projection. Nasal hump is still there because I was not doing nasal surgeries, and her nasolabial angle is much better, and we lengthen distance from here to there, so her soft tissue is draped over the skeleton nicely. So this is her surgery. It's double plating. This is her gap. No chin surgery, so she didn't need chin surgery at all. So we didn't even plan for that. She had perfect chin length and profile. But the thing is, this thing was short, so it looks squashed. So this is her bite approximately 2 months after surgery. This is her bite after. So this orthodontist was very brave, and they gave the patient positioner. Positioner is something that sinks the bite after surgery. The patient's joint was excellent. She only had clip, but her actual condyles were pretty large. So in this case, it was 6 years ago when I did this case. I didn't know too much about condylar resorption then. Just a little bit now. We have more knowledge of it. I probably not recommend the positioner, but it was okay. So you want to have retainers that do not have any plastic or wires in between the teeth. So acrylic is okay on the lingual surface, on the palatal, but nothing in between. The best retention is the big cusps and overjet that locks the bite. So stable result 2-3 years after. Again, she had upper jaw widening, so we widened her jaw, and lower jaw and upper jaw came forward, and she got cheek implant. No chin. What else did we do? We made her smile bigger. How? We advanced the upper jaw down. So when she smiles, she shows more teeth. When you smile on a female, You want to, at rest, show 3 millimeters of teeth at rest when you relax, and your mouth is a little bit open. And then you want to have, in that smile, show full length of teeth and maybe 1-2 millimeters of gum, ideally.